So it's my pleasure to introduce Dr. Keyvan Karkouti, who's the Chief of the Department of Anesthesia and Pain Management at University Health Network, Sinai Health System, and Women's College Hospital, and is a senior scientist who has really focused a lot on perioperative management of bleeding and transfusion. So I'm really excited to have him here to talk about patient blood management in the intraoperative period. Thanks so much, Keyvan.
Thank you very much, Julia. And it was as usual, it's a pleasure taking part in this session. I better not look at the number of attendees because it'll just make me nervous, I think. So, so thank you all for joining, and hopefully you'll leave the session with some practical and useful advice. Just to head right into it, there's 3 pillars of patient blood management. We're going to be focusing on the intraoperative part, and in the intraoperative part, there's essentially 3 topics or 3 general areas. One is to optimize erythropoiesis, and I'm not going to talk about this, as you just heard Julia's wonderful talk about that covered basically this important topic. One thing I guess that's a little bit would be an addition would be to schedule surgery with red cell mass in consideration. Doesn't mean it's the overriding consideration, but it's one of the considerations we need to have when we're looking at anemic patients undergoing major surgery. And it's always a difficult decision whether to delay surgery or not to treat anemia, but we should definitely consider it. And then IV iron, as you just heard about all the evidence. So that's all I'm going to say about those 2 topics. The second pillar is to minimize blood loss, and there's multiple ways we can do this intraoperatively, and I'm going to present these, the 5 that I've listed here, and essentially editorialize a little bit in terms of what the evidence is, what we use in our practice, and what the rationale for our decision is. So these are the areas I'm going to cover. And then the third part is managing anemia. And intraoperatively, it means improving the tolerance of anemia and evidence-based transfusion thresholds. So I'm just going to discard of the first one here because it really doesn't have any practical impact. There's a lot of things we can do to increase the tolerance of anemia during anesthesia, but patients obviously have to wake up and deal with the stress of surgery, with reduced respiratory function for atelectasis, pneumonia, et cetera, So oxygen delivery is increased, or the need for oxygen delivery is increased after surgery. So in my mind, artificially increasing the tolerance during the case really doesn't impact your transfusion rates because they're just going to need it after the case. It's for the same reason that, for example, hyperbaric oxygen therapy is not really a good blood conservation modality. We use it in extreme cases in JWs, but obviously patients can't stay in a hyperbaric chamber all the time. So we're going to discard with that as a blood management strategy. But I will talk about the transfusion thresholds. In my mind, there is very straightforward criteria for what I'm going to do in my practice in terms of blood management. And 1, it has to be effective. Number 2, it has to be as safe as transfusion. We know transfusion is very safe, but it has risks and costs. So at the very least, so that it has to match the safety of transfusion. And we do accept higher costs for blood management relative to transfusion, but I don't think we can accept less safety. And then the cost should be reasonable. It can't be through the roof, but we do accept, as I mentioned, higher costs to save transfusions. So anesthetic blood sparing techniques. There are several that we can use in terms of things that would have lasting impact on transfusions by reducing blood loss. And one of the things you'll read about is permissive hypotension, and that used to play a much bigger role in our practice than it does now. In fact, we used to call it controlled hypotension. And basically what that means is you lower the patient's blood pressure to a tolerable mean that you think is going to provide enough oxygen delivery and perfusion to vital organs, and at the same time be low enough to reduce surgical blood loss. The added advantage of that is that as you reduce the blood pressure, blood loss at the field is reduced too, so the surgeon actually sees better and there's improved visibility in the surgical field, making it technically easier and hopefully more accelerate the time of surgery or the duration of blood loss. There's many ways we can do this. When we used to do controlled hypotension, we would actually start intravenous short-acting medications such as vasodilators nitroglycerin, esmolol infusions, things like that, to actually reduce the blood pressure to 50 to 60, and that's when it was controlled hypotension. Now it's basically permissive hypotension, and the way we do that is we allow the patient's pressure to drop and not treat it when it drops in response to the anesthetic depth. Every anesthetic drug that we use has some effect on the circulatory system, including reducing myocardial contractility and vasodilation and increasing capacitance. So in that way, the blood pressure drops, and unless we treat it, you do get a natural drop in blood pressure. So we kind of let that happen. The other thing that's really hot right now is fluid restriction. So we used to, again, replace what we thought was fluid deficit intraoperatively, for example, by giving crystalloids, even for the amount of time patients were NPO. We would calculate how much fluid they would need to replace that, and so on. Now, though, the practice has shifted to the point that we actually, for some types of surgeries, we really keep patients dry. For example, for hepatic resection, our CVP that we aim for is about 0. So we do have techniques to do it, but we don't really actively drop the blood pressure unless it's, except for very rare circumstances. And then the risk is obvious here. Organ hypoperfusion and injury would be the main risk. There is some protection under anesthesia because, again, you're under anesthetic, your oxygen consumption for most organs is reduced. On the other hand, in a lot of times we don't know which organs are at risk. So, for example, you might have underlying carotid disease and your brain might be at risk, and other or kidney injury and things like that. What is the evidence that permissive hypotension actually work? Well, there is a fair amount of studies done, and it is supported by meta-analysis that in specific types of surgeries, and I've listed some of them here, it does actually reduce, it seems to reduce bleeding. But the studies, the meta-analysis, are based on small, low quality and outdated studies. And by that, I mean, the surgical procedures have substantially changed from when these studies were done. So that is procedure that used to lose liters of blood, for example, radical prostatectomy, now loses at most 200 to 300 cc's of blood. So any study that had radical prostatectomy, for example, included in this sort of in their procedures wouldn't really apply to modern surgery. And then the other problem is whenever you do meta-analysis on small, low-quality evidence, safety is not really assessed. So we don't know how safe permissive hypotension really is on a global basis. Neuraxial anesthesia, so doing epidurals for surgeries that you can. So for example, orthopedic surgery is commonly used, and there seems to be pretty good evidence that it actually does have an impact on blood loss. And the mechanism, we think, is because when you cause neuraxial blockade, your sympathetic system is, when you do neuraxial anesthesia, you get sympathetic blockade, which reduces your arterial pressure, reduces your venous pressure, so back bleeding is reduced. And then there's reduced surgical stress response, which may improve your coagulation. Just like the hypotension, though, there is conflicting evidence with older, lower quality evidence being positive and newer, higher quality evidence being negative in terms of its effectiveness as looking at it globally. And then a third one is acute normovolemic hemodilution, which again, we used to do before, but it's fallen out of practice. In this procedure, what you would have is a patient would come in for a large bleeding surgery. So prostatectomy was a common one we used to use it in. We would start 2 IVs. From one arm, we would take out blood, about 3 to 4 units of blood. And from the other arm, we would administer colloids. And then, in fact, we used starches for a number of years to do this to maintain euvolemia. And then the theory was that during surgery, the patient would lose the same amount of blood, but it would be lower concentration. So you've got a little calculation there in terms of the amount of blood that you could potentially save by doing this, in my mind, highly invasive procedure. So about 150 cc's of blood, or 2/3 of a unit, which is not a lot of blood. And looking back, we used to give starches, and we know those are not ideal colloids to use. So we probably did significant harm to a number of patients doing this procedure, which was based again on small, low quality evidence. So it really has no role in general practice in my mind right now, except in cardiac surgery, a modified version of this, where you take the patient's blood in the beginning, but you don't replace it and then give it back at the end. But that's a very subspecialized situation. Now I can talk about that more at the end. So looking at these techniques together, are they effective? Probably not. At most, borderline effectiveness. Are they as safe as transfusion? I don't know. There isn't good evidence to say how safe these things are for blood management. But we do know that they're pretty cheap. So they have 1 out of 3 going for them. But for the most part, these are not main drivers of intraoperative blood management. One dichotomy that I mentioned is that you have the old versus new study dichotomy, and that's repeated, I think, in this literature for various areas. And I basically mentioned this already. One thing I wanted to highlight is just because it's not effective on blood loss doesn't mean we don't use it. I mean, there are cases, for example, where we keep the pressure low to improve the visibility in the surgical field, allowing the surgeon to do the operation more quickly and more efficiently, and that alone would lead to reduced blood loss. So the driving factor here is what the surgeon needs rather than patient blood management. Cell salvage, Julia mentioned cell salvage as in response to one of the questions. It's a pretty straightforward technique. Model cell saver machines are very automated, and it's not very hard to train and use them. And depending on which hospital you go at, it's run by perfusionists, nurses, anesthesia assistants, anesthesiologists. So basically, it's relatively automated. They've got very good quality control built into them, so the end product is of very good red cells. And this procedure is straightforward. What you see here is you have the machine, and then you have the suction catheter. So blood loss comes here. The suction catheter gets blood that's sucked up, gets mixed with heparinized saline so that it doesn't clot, goes in a reservoir, and you can collect it here until there is enough to wash. So this component is about, I think, $60, $70. And so in surgeries where you have a high risk of bleeding, you can collect blood and not wash it unless you need to. Once you get to the washing, you get to about a $200 cost. It washes as using saline, and you get the washed blood back, and you can give that to the patients. Modern cell salvage has very few complications. I've listed the ones that are commonly reported, including hemolyzed red cells, air embolism, incomplete washing, infections if things aren't managed properly. But on balance, the blood that you get from a cell saver is safer than stored allogeneic blood. It's fresh, it's well washed. Hemolysis is not a major problem anymore. And in fact, you get it's been shown that you do get lower adverse event rates with cell saver blood than with allogeneic blood. There's some controversies whether how much of it you can give before running into problems. In my mind, it's limitless. Obviously, as you have to treat bleeding or coagulopathy as patients bleed more and more, because all you're giving back is red cells. But no matter how many units you get back, you can give. And despite that being, I think, pretty common practice, you're going to be faced with clinicians who, after a few units of cell saver, say, no, I don't want to give cell saver blood anymore, and I want to give allogeneic blood, and I really don't see the point of that. Indications are any procedure where you think the patient is going to lose a lot of blood, and if you're wrong, you've wasted $50, $60 in this reservoir costs, which is really, for these big operations, is not a significant cost. And then you have any situation where patients, you would have a hard time finding allogeneic blood, or they don't accept allogeneic. So JWs, Julia mentioned how we would go about making the cell saver acceptable for JWs. Benefits, we do know it does work. So it reduces transfusions on average by 0.7 units, but increases avoidance by about 45%. And it's much more effective when you have massive bleeding. So when you've only given 1 unit back, obviously it's not that effective. But if you've had to give 5, 6, 7 units of cell saver blood, you've saved a lot of allogeneic red cells. And the contraindications, there's very few absolute contraindications now, because we've got leukocyte depletion filters, which can take out bacterial contamination. There is a controversy about whether or not if you reinfuse tumor cells, it might cause metastatic, but that's been kind of refuted. But I'm a little bit conservative, so if there is contaminated surgical field, that should say malignancy, not malignance, then or sepsis, so an acute abdomen or something like that, I generally don't use a cell saver, but there's really no absolute contraindications. And it hits all three things that I talked about. It's effective, it's better than allogeneic red cell transfusions, and it's got pretty reasonable costs. 1 unit is significantly less than cost of an allogeneic blood. Next is pharmacological agents, and I've listed some of the ones that you're going to hear about here. I'm just going to talk about antifibrinolytics, but there is, DDAVP, prothrombin complex concentrates, fibrinogen concentrate, and factor VIIa. All of them there is literature on whether or not they could be used to reduce bleeding, but I'm not going to get into that. So all I'm going to talk about is antifibrinolytics. And the one we have in Canada is tranexamic acid. This is the mechanism of action. It's pretty straightforward. It's a lysine analog, and basically what it does is blocks the lysine binding site that you need to be empty so that you can get fibrinolysis. So what it does is it attaches itself over there, and the TPA plasminogen doesn't get activated to plasmin, and therefore you can't get fibrinolysis. What is its current status? It definitely works, but in some populations, there are some, depending on how enthusiastic some people are, they recommend that it be used in every case. More generally, the recommendations are that it only be used in high bleeding cases. And there is a lot of high-level evidence. This is probably the best blood management strategy, the best studied blood management strategy. And we do know that overall it reduces blood loss and transfusions by about 1/3. I'm going to show this indications in the next slide. And what I want to highlight before we get into the indications is that its benefits outweigh its risks, but not in every case. It's got absolute contraindications. So if you're allergic to tranexamic acid, which is pretty rare, I've never actually seen that, to be honest. But if you are hypercoagulable, I don't think you should be receiving tranexamic acid. And there are cases where hypercoagulability is very well masked, for example, in cirrhosis patients. And then there's caution to be, when you're using it, you should be cautious in patients who have a seizure risk. We do know that tranexamic acid increases seizures. It's controversial whether or not it's just lowering the threshold active or in some people who are at risk, but it has, in cardiac surgery at least, it's definitely shown that it increases seizures. In renal failure, accumulation might be causing problems. And if you've had a recent thromboembolic event, and cirrhosis, I mentioned, is another area where you might actually be hypercoagulable despite our coag assays showing hypocoagulability. So here's a slide from a nice review that just came out that looks at all the indications of tranexamic acid and suggests what we should use. Now, I'm not going to go over all of this, obviously, but as you can see, one side of it is cardiac surgery. So this is where most of the evidence is. And on pump cardiac surgery, there's no question that everybody should receive an antifibrinolytic drug. In the States, it's EACA. Here, we use tranexamic acid. Off pump, for high-risk surgeries, we still use tranexamic acid. The evidence is a lot weaker, but this is where we have most of the evidence. Then you get to the other areas, and you can see here you have different caveats for different things, but orthopedics, there's also a lot of evidence, and it's used commonly and routinely. Neurosurgery, you get into a little bit more controversial. Liver surgery, again, even more controversial, and then trauma, postpartum hemorrhage, and pediatric surgery, there's pretty good evidence for these three. So I'm going to go over evidence for cardiac surgery, trauma, and postpartum hemorrhage and GI bleed. There are a few uncertainties before I get into the evidence. One is the dosing. In the last slide, you could see there was different recommendations for different indications, which is basically taken from the latest studies. And unfortunately, all the studies use different dosing, and they don't go with what the pharmacokinetics of the drug is. What we do know is that about 10 milligrams per kilogram IV results in a concentration of 10 milligrams per liter in plasma, and that probably inhibits your fibrinolysis by 80%. And the question though is, some people say, well, you got to block at 100%. I can't think of any physiological reason why you'd want to block your fibrinolysis by 100%. But the question is, how much more does it take to go to 100% inhibition? And not surprisingly, it takes a lot more because, you know, the log curve applies here from 0 to 1. And as you get to 100%, you have to give a lot more. And it takes about 10 times that dose. So you got to get to 100 milligrams per kilogram to get 100% inhibition of your fibrinolysis. The studies use different dosages, and most of them not based on pharmacokinetics. And putting it all together, a reasonable dose in my mind in most settings would be 10 milligrams per kilogram bolus, followed by 1 milligram per kilogram per hour, given either as an infusion or as a bolus. It's a long-acting drug. Personally, I don't see the point of an infusion. I just give one amp every hour in a prolonged high-risk bleeding case, but you can run an infusion. Indications, the British recommendations are to offer it to all adults having surgical procedures with moderate, greater than 500 cc's blood loss. In my practice, it's a little bit more targeted than that. Going over some of the evidence, so this is the big trauma study, CRASH 2 study. It's been followed up by CRASH 3 and other things, but basically this came out in 2010, 10 years old now already, it's hard to believe. A large study, 20,000 patients. They gave 1 gram bolus followed by 1 gram infusion over 8 hours, and the primary outcome was 28-day in-hospital all-cause mortality. This was a multinational study run all over the world. So what you find here is that all-cause mortality was reduced in the which was their primary outcome, and bleeding was also significantly reduced with a relative risk of 90 or about 10 to 15% reduction. They had no increase in vascular occlusion, so thromboembolic events were not higher, but you can see how low that rate was, which raises questions about completeness of outcome assessment. The other thing they found was that the time to treatment was very important. So you can see up there, if it was given soon after trauma, within an hour, you had a substantial improvement in mortality as opposed to more than 3 hours where it actually seemed to be harmful. And there are some physiological reasons that would explain that, but that's an important finding. The one caveat though is there was wide variability in the geographic area in terms of timing of surgery. So if you look in the bottom there, if you look at more than 3 hours, the vast majority of patients came from Asia, whereas in the less than 1 hour, they came from North and South America and Europe. So there was a difference in terms of medical care, availability of medical care depending on the timing. So that's an important confounding. And the biggest weakness in my mind is whether or not this study is generalizable to our practice. It was a large study, but as you can see, very few patients came from developed countries, even from UK, where the study was run from, only 135 patients came from it. So it's definitely an important study, but you've got to keep these caveats in mind. In cardiac surgery, as I mentioned, we have a lot of evidence. This is the latest study that came out only 3 years ago, large study, so modern cardiac surgery, so it applies to our practice right now. And the dose they used was pretty high, 100 milligrams per kilogram. They found out that they were seeing a lot of seizures, and partway through the study, they cut that down to 50 milligrams per kilogram. And the primary outcome was 30-day mortality plus thromboembolic events. And what they found was that basically the death or thromboembolic event were a little bit lower in the tranexamic acid group, but not that big a deal. But the important thing we're finding was in blood product transfusion, you had a 30% reduction. Number of units was substantially reduced. And here you had a 7-fold increase in the risk of seizures. The absolute increase is low because it's a rare complication, but it went from 0.1% to 0.7%. But you do see that there is a significant increase in seizures. Postpartum hemorrhage, another big study, came out 3 years ago. Here they used 1 gram repeated times 1 if necessary. So these are along the lines of 10 milligrams per kilogram dosages. Primary outcome was 42-day all-cause mortality. And death or hysterectomy here overall was not significant, but death for bleeding was significantly lowered, and laparotomy for bleeding was significantly lowered. So here the question is, what, the primary outcome versus secondary outcome argument, it's a big argument, but in my mind, these are important outcomes, especially laparotomy for bleeding, for example, So this to me is a positive study. Looking at subgroups, there was some indication that timing might be important, but didn't reach significance with a P of 0.085. Beyond that, the pattern was similar in the subgroups assessed. And then adverse events rates were well looked at, and there was nothing that jumps out. So in a large group, it seems to be pretty safe and reduces bleeding. This is the most recent study that came out. This one was in GI bleed, and they looked at patients, 12,000 patients. They gave 1 gram plus 3 grams over 24 hours. The primary outcome was 5-day bleeding mortality. And what they found here was that there was no difference in the primary outcome or adverse events in terms of arterial thromboembolic events. But in terms of venous thromboembolic events and seizures, there was an increase in the tranexamic acid arm and no real reduction in transfusion rates. So here you have a negative study, and it actually highlights the fact that if you're giving tranexamic acid in a situation that's not going to benefit from it, you will see the adverse events show up. And here we do have increased thromboembolic events. One thing to keep in mind here, they gave it, it was higher in patients with liver disease and variceal bleeding. And as I mentioned before, liver disease is one of those areas of concern where you might see increased side effects because of tranexamic acid. Overall, though, putting it together, tranexamic acid is clearly safe and effective in the majority of situations, and it's pretty cheap. Each amp costs about $8. Actually, it's even less now, I think $6 to $8. So 10 milligrams per kilogram would be 1 amp in most patients. So repeating it one more time would give you 2 amps, so $16 or so. So it's a pretty cheap alternative that's highly effective. And to summarize all of that together, in my mind, I think if someone's bleeding excessively and it's not a procedure where you would use it typically prophylactically, so outside of cardiac surgery and orthopedics, let's say, then I would consider administering it, and the dose I would give would be 10 milligrams per kilogram followed by 1 milligram per kilogram per hour until the bleeding stops. Now moving on to the restrictive transfusion threshold. So I've got here the JAMA, the recommendations from the consensus conference that was published in JAMA 2 years ago now. And basically, this is the table of recommendations. As you can see, they have various patient population. And what stands out there is that they have various thresholds that aren't that much different. So in critically ill but stable patients, they say less than 70 grams per liter. In those undergoing cardiac surgery, less than 75, less than 80 for hip surgery. So it's pretty nuanced divisions. And in fact, an editorial that came out said that the thresholds are particularly specific, which to me tells me they're basing it simply on the latest large study that came out as opposed to looking at it globally and physiologically. And the other thing it tells me is that, one of our teaching is you should never base a hemoglobin measure as an important consideration when you're transfusing a patient, but it should never be the sole consideration. So what the ultimate clinical situation is actually more important than the single hemoglobin that you measure at a particular time point. Looking at some of the studies, looking at restrictive versus liberal. So this is Dr. Mazur's study from St. Mike's and the group that came out, very well done study. I just want to highlight some of the common things that are in all of these studies using this one as an example. So in this one, they use high-risk cardiac surgery. Patients were randomized before surgery. Restrictive group was a hemoglobin of less than 75. Liberal group was less than 95 during surgery or ICU stay, and less than 85 when they left the ICU and went on to the ward. It's underlined here that the protocol was suspended if rapid bleeding or hemodynamic instability due to bleeding occurred, and this is consistent in all of these restrictive versus liberal studies. So they don't apply to the bleeding or unstable patient. Usually they get this kind of a difference in terms of between group variability. So baseline was about 130, dropped to 90 after surgery started, And then once the intervention kicked in, you get about 10 grams per liter difference between the two arms. And so even though the thresholds are quite different, usually in practice, on average, you get about 10 gram per liter difference, which in my mind, if you take 1,000 patients or 10,000 patients, randomize them to that kind of a difference, invariably it's going to be a non-inferior study. You're not going to be able to show differences in those two arms in terms of outcomes. And in fact, that's what we're finding. We're finding that this sort of difference leads to substantial savings in transfusions. So it's a great PBM. But in terms of looking at adverse outcomes, there's usually no difference in mortality, composite outcome, or infections, because it's simply not designed to be able to detect those outcome differences. Overall, though, I think it's a very effective PBM. It's definitely safer than transfusion because you're actually not transfusing and you're not letting patients be that anemic. And it's, again, very cheap because all you're doing is nothing. But sometimes, remember, one of the hardest things to do is to do nothing. So some caveats. So the biggest one is, does it apply to your patient that's in front of you who's bleeding or who's expected to lose another few hundred cc's of blood over the next few hours and the hemoglobin is 80, for example? These studies did not apply to the bleeding unstable patients, and therefore they can't be applied generally. And don't forget that in other issues with surgery, patients are oftentimes coagulopathic, and we do know that the more anemic you are, the more coagulopathic you are. You do need your hemoglobin to be high if you're going to have your functioning platelets being optimized. And the other two things I mentioned. And then I'm just going to finish it up by talking about optimizing coagulation using point-of-care guided coagulation management strategies. So basically, when we talk about this, most times we're talking about viscoelastic testing, which is ROTEM and TEG. We use ROTEM, but TEG, they're very similar. And then platelet function assays, and there's multiple assays available, so I'm not going to go over those specifically. I'm just going to highlight one of the studies we did published in 2016, where we looked at the effectiveness of having a point-of-care based testing in cardiac surgery, randomized 12 hospitals to using standard of care or our algorithm. This is the algorithm. It was pretty straightforward. Basically, you do the usual stuff you do in cardiac surgery. It was very pragmatic. You confirm bleeding, and if they have bleeding based on your point-of-care testing, you either give platelets or you give correct the fibrinogen with cryo or fibrinogen concentrate, or correct coagulation factor deficiency or thrombin generation with PCCs or plasma. Viscoelastic assay, when you look at it, this is what a normal ROTEM looks like. So when you have basically different assays, we use the XTEM and the FIBTEM. The XTEM is the extrinsic pathway activated. And what happens is when you start the test, you get this line where you have initiation of clot formation. That's your clotting time. Then you get your uptake, which is your clot formation time, how long it takes to get to 20 millimeters. And then you get your maximum clot formation, which is the thickness of this arm at maximum point, or estimated at 10 minutes, which is the A10. This is the FIBTEM that takes away the platelet component of coagulation. So all you have is the fibrinogen component. So it's the same curve, except it's narrower because it's got no platelet activity left. So this is all your fibrinogen. And there's very good correlation between this thickness, so the A10 or the MCF, and the Klaus method of fibrinogen in terms of whether or not you have low fibrinogen. It doesn't tell you the exact value, but it tells us pretty well who's less than 1.5 grams per liter. So in that study, we had 7,400 patients. It was a cluster randomized trial. And overall, you can see these were the transfusion rates across our sample, which is pretty high. So cardiac surgery is still a high blood loss procedure where about half of the patients get red cells, about a quarter have major bleeding, and about a third get platelet and plasma transfusions. Looking at major bleeding, what stands out here, these are the 12 hospitals. We can see there was quite a bit of variability in major bleeding rates, and some of that is explained by patient factors, surgical factors, but a lot of it is unexplained. Nevertheless, what you can see is that in every hospital, except for one, pre-rate of major bleeding, which is in green, was higher than the post, which is, I guess, purple, except for one hospital. But this hospital, after risk adjustment, you see the same pattern. Overall, though, there was about a 20% reduction in major bleeding. That was significant with the number needed to treat of 22. We also saw a 10% reduction in red cell transfusions and about a 25% reduction in platelet transfusions. So, but no difference in adverse outcomes or processes of care. So optimizing coagulation is pretty effective. It's, again, you save transfusions and all you're doing is improving monitoring. And the costs are reasonable to do a full set of point of care assays. Platelet function and ROTEM is about $60 to $80 per patient. So it's not negligible, but it is reasonable. So to summarize, basically, we did not talk about this. We have minimizing blood loss. I mentioned that cell salvage, tranexamic acid, and point of care based coagulation algorithms are highly effective. Anesthetic blood sparing techniques and ANH, not so much. Improving tolerance of anemia, I dismissed early on, but evidence-based transfusion thresholds are highly effective PBMs.
So, okay. Yeah, thank you, Kim, for that excellent overview of all of the different options in terms of perioperative patient blood management. And I think your comment about sometimes it's hardest not to do anything when we talk about transfusions is a really good one to keep in mind. Okay, so Dr. Karkouti, the first question, I understand dropping blood pressure by vasodilation. However, reducing blood pressure by reducing cardiac output seems counterintuitive. Can you explain?
Yeah, no, we don't reduce. So you're absolutely right. I mean, we would not drop cardiac output just to drop the pressure. What I meant is that the anesthetic side effects or the anesthetic drugs that we use have side effects. And together, those things lead to a reduced blood pressure. And sometimes we're aggressive in correcting that, and sometimes we're not, depending on whether or not that's advantageous for surgery, what the patient's underlying risk factor is. So if you have an elderly patient with poor LV function who becomes hypotensive after induction, I would jump on that very quickly and correct the drop in blood pressure with either increasing contractility or correcting the vasodilation. But in a young patient who's having ENT surgery where the surgeon really wants the blood pressure or good visibility or low blood pressure really helps the surgeon in terms of visibility, I would just I would probably just leave it alone and not correct it, because I know this, despite the fact that the contractility is fallen, and there's still good perfusion to all of that patient's organs, so I would not correct it. But no, I wasn't suggesting that we would drop contractility for controlled hypotension.
Thank you. Okay, the next question. Could you speak on the suitability of tranexamic acid for patients that are post-cardiac stent insertion? So for example, if they were, in the first year post like drug-eluting stent, for example, versus, remote more than a year after.
I think I'm gonna have to give the answer that my, first year, the only thing I remember from my undergrad years is my first year university psych teacher who said the answer to every question can be, it depends. So I think it depends what they're having. So if they're coming for heart surgery, for example, yeah, absolutely we would use tranexamic acid, because one, they're gonna have those vessels bypassed, and two, the risk of bleeding is pretty high. But if they're having for other procedures, I would, if it's a fresh stent, then I probably would not give tranexamic acid in most situations, I think. But you're probably going to hear different answers from different people. But in my mind, I think that's pretty high risk, and I would take the little bit of chance of excess bleeding as opposed to blocking that new stent.
Is the tranexamic acid dose based on total body weight or ideal body weight?
I wish I could say we were that specific, but I would just say I would base it on the ideal body weight as opposed to total body weight. But again, the dosing, as I alluded to, is all over the place. So there is no firm answer to that. But 10 milligram per kilogram, on average, I think the loading dose should be 1 amp. So I rounded up to 1 gram. And so I base it on ideal body weight.
Yeah, it's a good question. I don't know about the how lipophilic tranexamic acid is. We'll look it up and think about In the cardiac surgery tranexamic acid trial, did the seizure rate decrease when they decreased the dose of tranexamic acid?
I think so. I have to read it again to be 100% sure, but yeah, I mean, the study continued. It was early on when they switched from 100 to 50, and they continued till the end. So I suspect that they did see a benefit. We ourselves used to use 100 cc's, 100 milligrams per kilo, going back 15 years or so, 10, 15 years, and we did see a lot of seizures. So we have cut down. Right now, our dose is 25 milligrams per kilo for low risk cardiac surgery, and up to maximum of 50 milligrams per kilo. So we don't go past 50 anymore.
How would you explain the lack of benefit of tranexamic acid in GI bleeding and halted, as opposed to the other positive trials like CRASH-2?
So that's a really good question. I think if you look at, I'm going to revert or talk about the cirrhotic patient and why we don't use tranexamic acid in cirrhosis. One is the fact, even though your INR might be up, we know all your coagulation proteins production is dropped in cirrhotic patients. So on balance, you might actually be more hypercoagulable. So when we do liver resections, there's a study I think ongoing in liver resections. But when we do liver transplants, for example, we don't use tranexamic acid, whereas a lot of other centers do. The concern is causing portal vein thrombosis in liver surgery. So I think when a cirrhotic patient comes in, you don't know what the underlying coagulation status is, and you're giving a procoagulant, you expose them to the risk if they're hypercoagulable. The other thing is, is the bleeding caused by excess fibrinolysis or not, and does the patient have any chance of benefiting from the drug? And if the bleeding is free-flowing and it's not really related to fibrinolysis, then giving tranexamic acid isn't going to stop the bleeding. Surgery or some sort of intervention is going to stop it. So you've got no benefit from the drug and potentially exposed to the risk, and that probably got unmasked there. And that's really the best explanation I have.
When giving tranexamic prophylactically, we usually give 1 gram over 15 to 20 minutes. In a rescue manner, we usually give it rather quickly, like over 2 to 3 minutes or push. Do you think there's any risks of giving it by push or slower bolus? What would you recommend for a bolus infusion rate?
I think if the patient is anesthetized, then it doesn't matter. We just bolus it. I literally just shoot it in. In an awake patient, you do get the side effects of it. So if the patient's awake, it has to be slow. But if an anesthetized patient, I think a bolus is pretty safe.
And what side effects do you usually see in like the more awake patient?
That's a good question. It's not coming to me right now, but I think they definitely get nausea and vomiting. But there's other things too. I forget what they are, but it's not comfortable. They don't get a comfortable feeling. I've never given it to an awake patient, so I don't know, but it is not comfortable, I've been told.
Yeah, I think it's mostly the GI, like some GI nausea, upset with it. In the setting of trauma patients, is it clear why tranexamic acid is only effective if given early?
I can well, no, the short answer is no. I think we can kind of or hypothesize that, as bleeding, like everything else, if you nip it in the bud early, then you don't get into a vicious cycle of problems. It's probably more risky as the patient bleeds and becomes more, gets into more of a DIC situation. So if several hours have gone by post-trauma and you stop the fibrinolysis and they're in a DIC physiological situation, then that could cause adverse events. And then the other thing is, the more you've bled, the more coagulation factors you've lost. So even if you stop the process, they're still pretty coagulopathic. So there are a lot of reasons why giving anything in any situation, giving it early is better than late. And in cardiac surgery, we have the luxury of being able to give it prophylactically because the patients, we know exactly when they're going to start having the problem. Whereas in trauma, you don't. The patients come after X number of time from the injury, so you're kind of bound by what you're faced. So the sooner you give it, the better. If it's gone past a few hours, then I would really think hard whether or not the patient would benefit from it or be more harmed by it.
Okay, and I'm just going to do the last question, which is, is pregnancy considered a hypocoagulable state for administration of tranexamic acid purposes? Is tranexamic acid safe in pregnancy?
So I don't know what if you mean by like prophylactically to every patient. I mean, I would never. I don't think it's in a postpartum hemorrhage situation. Then I think it is safe, and that was a pretty large study that showed that it is safe and effective. But prophylactically in high risk deliveries, let's say, I don't think it has a role in that.
Okay, thanks so much, Dr. Karkouti.